So I don't think, I originally sort of thought I'll start with talking about my professional identity, but I think that you've had more than an earful about that. So I'm going to talk a little bit about my personal identity before I talk about my perspective. So I want to start by just stating up front and very consciously that this is not an easy road to walk, and yet I walk this road with enormous privilege. I am well educated. I was born and grew up in this country. I'm fluent in 2 languages. I work in settings, have always worked in settings where I've been very well insured, the public health department, Kaiser, UCSF, and I'm able to navigate systems often from the inside. And so anything that I say about our experience as a family, you can multiply it times 1,000 for those who come from less privilege or different kinds of experiences. So I'm going to try and kind of balance speaking as a provider and speaking as a parent. We are a 2-parent family, 2 moms. We are a multi-ethnic, multiracial, multilingual family. I have a 26-year-old son and a 17-year-old daughter. Both my kids are adopted. And my 17-year-old has cerebral palsy. Her specific condition is schizencephaly, which means that her brain has some unusual clefts, valleys, and gyrations, which make it that the way the typical brain connects, her brain doesn't connect. And this has resulted in a lot of physical disability, some unusual approaches to learning and processing information, but a pretty together head. So cognitively, my daughter has always been a full inclusion student in the public school system in San Francisco. She's at grade level, and she hopes one day to be at UCB training to be a social worker and work with kids with special needs. So and her name is Maida. And Maida has really, she's a wonderful young woman who has taught us an enormous amount and also has created huge challenges for us as a family. So I want to start by talking about, as a provider, providing services to youth with special health care needs, because somehow this kind of became my niche in our clinic. I think part of that is a product of the fact that I have a lot of empathy and I have that lived experience. And I could provide continuity of care and an ability, a level of knowledge about systems that many healthcare providers don't have. I am well trained. I got my master's at UCLA. I never learned a thing about the care of children with special health care needs. Everything I know has been on-the-ground learning, and most of it has been originally motivated by my own personal experience. And I do not think that's unique. I think that, I trained 30 plus years ago. I think that things are changing some, but I don't think that they've changed nearly as much as they need to. And I teach in an FNP program and have a personal commitment to, infusing this content, and yet it's a tiny little bit that our students get and that our trainees get. And I think that we need to really look at that as we turn to expecting providers to really be knowledgeable, to coordinate care, to coordinate systems, to understand systems, especially in an era of huge pressures around productivity. I've personally been given the message you need to spread your patient panel around because there's just not time for you to provide the level of care that needs to be provided if you're only seeing youth with special health care needs. I work in a clinic that serves 12 to 26-year-olds, so I have a lot of transition age youth in my practice. For providers, in addition to not being trained, paperwork is overwhelming and it's redundant. And as an NP, I have to say sometimes even things like authorizations for diapers require physician's signature. This is because there are policies and laws that are antiquated and not responsive. I shared with my table this morning, when you have, there's a lot of issues to take care of, and when every 3 months you have to fill out redundant paperwork to authorize a 24-year-old getting diapers, what 24-year-old wants diapers? Really, are we worried about diversion of resources that we need to reauthorize with a physician's signature in triplicate and mailed? These systems just are not very functional. Agency and service providers all have their own forms, so there's an enormous amount of, annual updates that you need to provide to many, as a provider, to many different systems. There's no reimbursements in the kind of systemic reimbursement for time spent when the patient is not in the room, and yet a huge amount of work needs to be done by primary care providers and specialists when the patient or family is not in the room. And as I mentioned, there's a huge amount of pressure around time and a personal, moral, and ethical commitment to quality, and those things can really contradict each other, especially when your allotted 20 minutes are taken greeting the family, helping the youth get disrobed and up onto the exam table, which usually entails also waiting for the only room that has an exam table that actually gets low enough that they can even get on. So these are huge impediments as a provider that absolutely impact on the quality of care for youth and families, or children and families, because it makes it really impacts on the family's experience and care. As a parent, I think, all parents, certainly parents of young children, will tell you that life is overwhelming, that work-life balance is challenging. You can multiply and amplify that. So any of you in the room who are parents who don't have a child with special health care needs, but have faced the challenges of parenting, know that it's a really big job. Add on top of that, that for my family and for many families with children with special health care needs, you never get a solid night's sleep. I have a child with mobility disabilities. Bed mobility is a problem. She's 17 years old. I'm up usually at least 3 times a night because her feet have fallen asleep. They're tingling. She needs to be turned. So that just kind of layers on that sense of overwhelm. Everybody has lots of things they think you should be doing. At least 20 minutes of belly lying at least 3 times a day, standing in the standing frame, getting to school on time, hygiene, showering, learning self-care skills, homework, a family endeavor when you have a child who has learning differences and needs a lot of support in order to remain at grade level. And so, again, just try and listen to how those, and I know you all know this because you work with families, and some of you are families and parents of children with special needs, but it really can be quite a gigantic, enormous job description. And when you add on top of that being a full-time professional, a worker, a spouse, a parent, and a medical case manager, something's got to fall off. And often what falls off are those really instrumental relationships that help you maintain your ability to keep on keeping on. So the medical case management piece I'm going to come back to. I am absolutely committed to family-centered care and parental involvement, but I think sometimes the system has an expectation of our level of involvement that can be quite overwhelming. So let's see, where am I? Parent-to-parent support. What saved our lives early on was parent-to-parent support. Support for families in San Francisco has been an incredible resource. When my daughter was diagnosed with CP at 10 months by an orthopedist who held her up and said, "Oh, looks like she might have some kind of a brain problem because her feet are sticking straight down." Not a very gentle introduction to her diagnosis. Support for family was the first place we went and has always been our go-to resource. Parents don't have a horse in the race in terms of whether you deserve the services that you feel you need. Parents know that the services you believe you need are the services that you need, and don't have that bias of trying to filter whether, it's really just facilitation and support. And there's a huge need for facilitation and support. Over the years, CCS has really been the glue for our services, the most consistent providers, the people who know our family, the people who know my daughter. We have received therapy services. We're privately insured. As I said, I work for UC and before that the health department. So, but we've received therapy services through CCS since she was a very little girl. I think often the perception from the outside is that school is the glue. School is not the glue. It hasn't been the glue for us, and I don't think it's been the glue for many families. But CCS has been an incredible resource for us, and many of our therapists, because they're seasoned therapists, they know the resources. They can help us figure out where we need to go next, or who might be the payer source for a certain service or a piece of equipment or whatever that we might need. As a parent, when you go for care, you leave with this huge list of duties, tons of specialty referrals. I'm a primary care provider. It's been challenging for me to keep my own child in primary care because how many medical appointments can you do in a period of time? It is a fragmented system, and I'm at one of those centers. We started out at Kaiser. At the time that my child was diagnosed, the pediatric neurologist was leaving. They had no pediatric neurologist. We were going to South City for these services and the East Bay for those services, and almost no services in San Francisco where we lived. And so we changed systems and decided, well, at least I work at UC. I'm on faculty in the Department of Pediatrics. This should be an easier system to navigate. And I believe it has been, but only because I can work it from the inside. And by working it from the inside, and the other thing is nobody gives you a sense of priority. So you get this sheaf of referrals, you get this list of activities you're supposed to engage in, but nobody helps you sort out what do we really need to do right away, what can wait, and so it's sort of like whatever's the low-hanging fruit, that's where you start out. And it's not always the most important thing. It might just be the easiest thing to get done. For me, really, relationships have furthered, not only for myself and my own child, but for my clients, because I know the person in pediatric authorizations, and I can walk over and knock on her door, and she smiles at me and says, "What's up today, Erica?" And I can facilitate those referrals that otherwise might sit and sit and sit because there's so many, and they're all important, and for the family of that child, they're the most important. And yet, how do they get prioritized? How do they move through the system? How is there any feedback? How do families know whether they need to bird dog the issue or whether somebody else is going to take care of it for them? Families have to be ready to fight for every referral, for every service, for every piece of durable medical equipment, even insured families. So, the mantra at my house is you put it in the request, you get the denial, you do the appeal, you get the denial, you do the next appeal, you get the denial, you send in the grievance letter. Often at that point it gets granted because it's cheaper for them to stop fighting and just cough up the service or the piece of equipment. That's very labor intensive. We have two educated parents in my family. One is an immigrant who, for all intents and purposes, seems to be absolutely acculturated and bilingual, but when it comes to this kind of stuff, she doesn't touch it. And she's well educated. So when you think about other families where there are language and cultural issues, it just doesn't happen. You get the denial and you go, oh, guess we can't have that. Guess we don't deserve that. Guess that doesn't exist for my child. Instead of, going back and fighting. And it always takes a really long time because the system takes a long time, and if you have a lot of things on your plate, it's easy for something to fall off. And so it's always the most pressing need that might get addressed. And some of those other needs that are really important in the long run may not get addressed until maybe too late. So I'm going to move on to what might make a difference from a family and provider perspective. So these are the things I would posit. I don't know if they're possible. They would make a big difference. I'll share with you that for many years in the public health department, I worked with youth in non-healthcare settings, so incarcerated youth, homeless, street, runaway youth. We had a homeless youth network where we tried to coordinate services, and we would meet together, and we would talk about, we had authorization from the youth who were receiving services to discuss, and we would talk about the youth we were serving, and we would see that there might be 6, 8, 10 helping professionals involved with one kid. And the joke was always, maybe we should each take a kid home. Maybe they get better care that way, instead of having these bureaucratic systems that don't quite meet their needs. So I'm not saying that we should each take a kid home, but I do think that each kid needs a home, and I'm not sure that I think that the concept of a medical home is a great concept. I think the application is extremely uneven. What would be helpful? Universal intake and reasonably timed updates. How many times did I or any parent of a child with a disability under 5 have to fill out a comprehensive intake form for one agency or another that asks the same questions, which sometimes become rather painful to answer? It gets hard to say, no, she doesn't roll over. No, she can't sit up by herself. No, she doesn't walk. And then after a while, it gets kind of like okay, when did she start speaking? Seems like she's always talked, or, so you tend to forget the deficits, like they just didn't happen, and then you can't even remember with the strengths that you're so dependent on. So this process of redundancy is, and they're also like 10-page forms that you fill out over and over and over with the same information. There's got to be a way that we can coordinate that, and that families can have one intake that's shared. I mean, I sign a thing for the regional center, for CCS, for my healthcare provider, saying they have permission to talk to everybody and their brother, and yet they don't. And every single system has their own set of intake forms. Goal setting, great idea. It's a learned skill. When I had a 10-month-old who wasn't really sitting steadily on her own, wasn't crawling, wasn't moving, and they asked me, what are your goals for your child? That my child be okay. Now, as the parent of a 17-year-old, it's much more concrete. I can really answer that question. I've had 17 years to practice goal setting for my child, not something you do with your typically developing children. And it's more developmentally appropriate at certain times in a child's life than others. And yet it becomes a very burdensome process for parents, or at least for us. Periodic updates make sense, but they should be periodic updates that make sense. So what is the, what are the time increments? What makes sense? What's a stable condition? What's a changing condition? Why do you have to keep talking about stable conditions over and over and over again? I would ask of systems that they ask what's useful and pertinent, not everything anybody might possibly ever want to know. Do it in a stepwise supportive process rather than sending this big fat envelope about 2 weeks before the appointment that is full of tons of papers that a family is supposed to prioritize filling out for the 11th time. And involve a professional or a paraprofessional to support or guide the process rather than leaving families on their own to figure it out themselves. I think I've been hearing a lot of talk about systems, and they'll talk about the regional center system. Because it's like this silo off by itself. It's hard for parents to understand what services, who's eligible and what services are available. What is the role of the regional center? And do they really have the capacity to meet that mandate, which I would really question. What is a family-centered medical home? And can we count on that model as something that can really support families? What's the interaction between the regional center and the service providers? Again, we give permission, but the connection doesn't happen. And that's not to fault any person or provider in these systems, but when you have a caseload, the social workers at the regional center have these ginormous caseloads, how can they possibly individualize care? So it's on a need-to-know, emergent basis. Private insurance is a source of additional work and not always a source of additional resources. My daughter, when she became more medically complicated because of poor surgical outcomes, all of a sudden we got a lot of attention from our private insurance when she was about 14 because she got really expensive all of a sudden. And so we got this nurse case manager through our private insurance who had no idea, no understanding of her diagnosis, of the systems of care, of the resources, of the needs. I spent more time educating her than she spent providing services for me. And I was in a position where I could educate her. But many recipients of that service aren't in that position. It causes a lot of anxiety and distress because you get these huge bills and you get these denials and there's nobody to help you with that system and you really feel like you're fighting an upstream battle. Families really need a designated advocate or navigator or somebody who can be consistent, who can know the family, who can understand the needs of the child and help families navigate the system. And that's not just for publicly insured families. I really think that, again, level of need is different, complexity of disability or chronic condition is different. All of these things impact, but everybody could benefit from a go-to person that can help them navigate systems, who knows the systems, not somebody that we need to teach about the systems in order to get the help to navigate them. Transition planning is great. There's been a lot of new attention paid to it, but as a provider in a system that sees young people up to 26, transition to where? To what? We don't have an adult care system that in any ways, as many problems, deficits, and challenges as we have in the children's care system, these kids grow up and they move into a system where there's almost nothing. And many of them who receive services lose those services at 21. If they're not regional center clients, they would lose services at 21. If they are regional center clients, they don't have the same level of service and support. And private insurance, for example, my private insurance never ever paid for any PT or OPT services. Only post-op, and not even really then. And then the last thing I'll say is schools. So, there's this transition at either if you're, in the preschool system, public preschool system at maybe age 3, and otherwise at about age 5, where all of a sudden the school is supposed to be the nexus, the locus of services. The school becomes another gigantic job for the family. It's a whole different system. It's a whole different sheaf of papers. You are refused services in other places because the school's supposed to provide them, and yet they don't. They also are overextended and under-resourced. We have spent years and years having OT and PT, quote, consult services through the school and services through CCS, where we're constantly saying to the school person, we have this therapist who knows our child, who's working on goals. Here's the report. Here's the papers. Maybe you could coordinate. Doesn't happen. At my daughter's IEP was our CCS therapists, who are wonderful and committed people, were there to talk with the school therapists. But does it happen anytime other than that, 1 hour where everybody's like, and let's get the, let's set the goals. And I mean, it's really, IEPs are another really interesting experience. But I think that in talking about services, to not talk about how services interact with schools and how schools interact with services is a mistake, because where our children are for most of the day, most of the year, is in school. And if they don't have the equipment, the support, the material, the understanding, the resources that they need there, then they're not able to really thrive and blossom. And so I just want to make sure that schools are on the table, and I think with that I will stop.
How about we entertain 1 or 2 questions?
Uh-huh.
Who should be the case manager? Who is this unifying person?
This unifying, so, I think that there's probably not one answer to that. I do not think it's necessarily a master's prepared social worker or a therapist. It could be a paraprofessional who's trained and supported and has, that backup. I think that, when we talk about children with special health care needs, could you talk about a broader group of children's diagnoses and needs and families? It's just huge. And so I don't think it's a one-size-fits-all, but I think the concept is.
A follow-up question. For a parent in this process, that's a difficult answer, because the system understands the system, but the parent usually doesn't. And for a parent coming into the system, how do they know how to identify that person? Where do they start?
So, what I said, for our family, we started with a parent-to-parent network. And that really was our best resource and has continued to be an enduringly supportive resource, but also has its limitations. So I think as a parent, what is most reassuring is someone who is knowledgeable about resources, who doesn't send you places where you don't qualify, so really understands what are the inclusion and exclusion criteria for services, who's resourceful, and who's available. So who is that? I don't know. But I can definitely say that it would make a huge difference, at least from my perspective as a parent. Sometimes it's really hard to sort out, what you keep knocking on one door and you're not getting an answer, and a year later you find out it was the wrong door to knock on. But nobody ever said, oh, we don't do that, but this folks down the street, these folks, they do that. But nobody tells you that. So somebody who really has a systems perspective and is knowledgeable and compassionate and empathic and all of those wonderful skills.